A few years ago, a friend of mine had a bone marrow transplant. He told me afterwards that the strangest part was not the illness and it was not the chemotherapy. It was the sentence the doctors used when it was over. They told him the transplant had worked and that now they would have to watch him for months to see whether it would start attacking him. I remember thinking that I must have misheard that. I had not. Now, I should say where I stand, because this video is going to end with an opinion. I think the thing that was approved at the end of June is the most interesting development in transplant medicine in about 30 years. I also think almost nobody outside the field has noticed, and that the reason is that the achievement is invisible. Nothing new was invented here. Something old was sorted. Because this is the bargain sitting at the center of blood cancer treatment. A transplant from another person is the only reliably curative option for many of these cancers. And the same donor cells that cure you can turn on your skin, your gut, your liver, and your eyes, sometimes for the rest of your life. And if you asked most people what the danger of a transplant is, they would say rejection, the body attacking the graft. But you know what? In this particular operation, the arrow points the other way. The graft attacks the body. It is called graft versus host disease, and in its chronic form, it is not an event that happens to you. It is a tenant that moves in. So here is what we are going to do. First, I want to show you why a transplant that works can still quietly ruin a life. Then, why the obvious solution, which is simply switching the donor cells off, has been the wrong answer for 50 years. And finally, the big one. What this company actually did, what the trial showed, and what it is going to ask of the rest of us. First up, what is actually being transplanted? It is not an organ, it is a population. When doctors give you someone else's bone marrow, they are giving you their blood-forming stem cells, and traveling alongside those stem cells are mature immune cells that have spent decades learning one particular human body in enormous detail. Yours is not the one they learned. Those donor cells arrive and they begin reading your tissue, the way a customs officer reads a passport in a language they only half recognize. Most of it checks out, some of it does not. And the cells that decide it does not are extremely good at their work, because that is precisely the work. Find the thing that does not belong here and destroy it. Which is exactly why you want them. Those same donor cells hunt down the last surviving cancer cells, the ones the chemotherapy missed. Doctors call that graft versus leukemia, and it is a large part of why the transplant cures anything at all. So the cells that damage you are the cells that save you. Suppress them completely, and the cancer comes back. That is the trade-off, and for 50 years, medicine has managed it with a blunt instrument. Drugs that suppress the entire immune system, given for months and sometimes for years, with everything that implies about infection and exhaustion. It works, in the sense that a dimmer switch works on a house where you only ever wanted to darken one room. So the question this field has been circling for decades is not how to switch the donor cells off after they arrive. It is whether you could send them in with their brakes already fitted. And it turns out that you can, because the immune system already builds the brakes itself. There is a class of cell called a regulatory T cell, a TREG, whose entire function is restraint. It does not attack anything. It stands beside the cells that do, and it tells them to stand down. They are the reason your immune system does not, on an ordinary Tuesday, decide to attack you. So the idea is obvious, and it is genuinely old. Put more of the brakes into the graft. The problem was never the concept. The problem is that a TREG is a rare cell hiding in an enormous crowd of cells that look almost exactly like it. And if you want to add a controlled number of them to a transplant, you first have to find them, reliably, in a bag of somebody else's blood. Which is what this company, OrcaBio, spent years building. Not a drug, a sorting process. They take the donor's blood, separate it into its parts, and then rebuild the graft to a specification. Purified regulatory T cells, blood-forming stem cells, and a measured dose of the conventional T cells that do the fighting. The same ingredients an ordinary transplant already contains, assembled deliberately instead of simply arriving as a crowd. On the 30th of June, the American regulator approved it under the name Trexi. It is the first regulatory T-cell therapy ever approved for anything. The trial is called Precision-T. 187 patients across 19 transplant centers, randomly assigned between the engineered graft and a standard one. And the number this field had been waiting on for 20 years is survival without chronic graft versus host disease. 78% against 38%, more than double. The rate of chronic graft versus host disease itself fell from 44% down to 13%. And overall survival, which is the number that is hardest to move and matters most, was 94% against 83%. Let me translate that. Out of every 100 people who would have gone home cured and then spent the following years being treated for the cure, most of them now simply do not. That is not a better drug for a symptom. That is the same operation, with its worst complication largely engineered out of it in advance. And honestly, this is the part that irritates me. The biology here is not new. These cells were characterized in the 1990s. The idea of adding them to a graft has been sitting in the literature for the better part of 20 years. What stood between the idea and the patient was never insight. It was the unglamorous, unfundable, decade-long work of learning to sort cells accurately enough to do it the same way twice. Now, to be fair to the skeptics, there are real limits here. This was one trial in adults with matched donors at 19 specialist centers, which is to say under close to ideal conditions. A graft like this has to be manufactured for each individual patient against a clock, and that supply chain is the part most likely to disappoint. Cell therapies are also priced like almost nothing else in medicine, and the people who need this most are rarely living near a center that can deliver it. But I think the direction matters more than the caveats do. For 50 years, the answer to an immune system behaving badly was to suppress it broadly and then manage the damage. This is the opposite instinct. Give the system the right composition at the start, and then leave it alone. If that generalizes even partly to organ transplants or to autoimmune disease, it is a different way of practicing medicine. And it is worth sitting with what the achievement here actually is. Nothing was invented. Every cell in that graft came out of an ordinary human donor. Nobody edited a gene. The entire advance is knowing precisely which cells to keep and in what proportion. It is the difference between a crowd and an orchestra, and the whole of that difference is knowing who should be standing where. My friend is well, and he has been for years now. He was lucky, and he knows it, and he still describes the waiting as the worst part of all of it. Being cured and being watched at the same time. I do not think we have abolished that. But for the first time, the chances of that particular sentence being said out loud have roughly halved. That seemed like a good thing to have done quietly at the end of a June.